we're going to do a quick recap of timing of initiation of renal replacement therapy in ICU. So the classic paper I sent out was a STAART-AKI, which isn't actually that classic. It was only published last year, which was, until AKIKI 2, the most recent paper. But I'm just going to do a quick hop through some of the history to lead up to AKIKI 2, and then Kat's going to kindly present AKIKI 2 for us all. So we know that renal failure in ICU is common. We know that it significantly increases mortality as an independent risk factor. We know there's lots of classic indications for commencing renal replacement therapy that we're all very comfortable with and happy with, so absolute indications. And then there's some middle ground, but perhaps before that, where different clinicians might find there might be some variations in practice with regards to exact timing. There was a systematic review meta-analysis published in 2015 in Quick Care that tried to pull all this evidence together and answer the question whether early renal replacement therapy is a good thing, and it basically found insufficient evidence, lots of heterogeneity amongst the studies. There were only 2 randomised control studies.
Eden,
yes?
we can't see your slides if you are sharing them.
Oh. Great, I am sharing them. There was significant does anybody good at computers?
Just go back to Teams.
Mm.
And probably easiest just to share your desktop, the far left. That one. Yeah.
Can you see now?
Yeah.
So the only 2 randomised control studies in that meta-analysis were both in cardiac surgery patients, so quite like a niche population. So there are potentially some benefits of starting renal replacement therapy early. So first of all, you get to avoid acid-base disturbance, and rather than wait for that to become an issue, sort of manage it early. You can optimise your fluid balance early. You can, there's potential advantages of maybe toxin removal if you believe in that, from your cytokine storm, such as in sepsis. But then potentially there's a benefit of waiting a bit, because maybe there'll be renal recovery and it's not actually indicated, and you've not subjected the patient to the potential harms of, first of all, line insertion, then ongoing presence of a line, and then actually potentially renal replacement therapy itself has got its own harms. I'll go on to talk a bit more about some hypotheses about that later, but things like hypotension and hypophosphatemia and disequilibrium syndrome and so forth from rapid shifts and rapid corrections that we might sometimes see. So the studies, so Elaine and AKIKI were both published in 2016. Elaine's a single centre German trial that used the KDIGO classification I've just put there in the top corner for those of you who don't remember it too clearly, but really sort of focus around 2 and 3. So stage 2 is where your creatinine's increased by a factor of 2 to 3, or you've got a oliguria of less than 0.5 mils per kilo per hour for 12 hours or more. And KDIGO 3 is where you're more than 3 times your baseline creatinine, or you've been essentially oligoanuric for about 24 hours. So what they wanted to do, they wanted to pick a subset of patients that have been otherwise optimised appropriately from a fluid balance perspective, that they had a good cardiac output, they had an optimised blood pressure. They used a biomarker that we don't use called NGAL, just a sort of a renal specific biomarker. And they wanted to make sure that the patients were properly sick patients, and we weren't just putting inappropriate patients on. So they needed to have severe sepsis and the use of vasopressors, be for active treatment. And the nice thing about the study is they tried to stratify the groups, so there was an equal proportion of those who were oligoanuric in both arms, but equal distribution of patients with cardiovascular instability, and based on the SOFA score as well. And they were randomised to either early, so within 8 hours of hitting stage 2, or late, which was within 12 hours of hitting stage 3 renal replacement therapy. Now you'll have your own opinions as to where you would lie with regards to your standard baseline practice. And they looked at primary outcome was mortality at 90 days, and they found a significant benefit in early renal replacement therapy. So this is one of the trials that says yay to early renal replacement therapy. However, there are lots of caveats to that. They were all surgical and very heavy cardiac surgery based. So almost half the patients were post-cardiac surgery, and therefore perhaps not extrapolatable to our general ICU population and more akin to those couple of RCTs that we talked about in the cardiac group. They did find that those who had renal replacement therapy started early tended to have a much shorter duration of requiring renal replacement therapy, so 9 versus 25 days, and they had reduced mechanical ventilation and ICU length of stay. So that's the single centre, so all the caveats with that German trial. The same year, a multi-centre French trial called AKIKI, this is AKIKI 1, I guess, was published in NEJM. So this is a multi-centre randomised control trial of adults admitted to ICU with acute kidney injury of most likely etiology being acute tubular necrosis, and as their marker of sickness they had to be mechanically ventilated and on catecholamines. They excluded what they considered, and I think it's perfectly reasonable looking at that list, things that would patients who met absolute indications for starting dialysis. So if you had a pH of less than 7.15 from a pure metabolic acidosis, if you had a urea over 40, you were hyperkalemic, you were pulmonary edema with severe hypoxia caused by your pulmonary edema, you were obviously excluded. Now, just think how this differs from the previous trial. This is KDIGO stage 3 rather than 2 and 3, and they said early was within 6 hours of stage 3, hitting stage 3 criteria. And then the delayed was either you met the absolute criteria or you were essentially oligoanuric for more than 72 hours. So both groups are later and one's potentially much later. Their outcome was 60-day mortality, and there was absolutely no difference. If you look in the study in a little bit more detail, the thing that's interesting is that the people who did best were those people who were randomised to the late arm and then never got dialysis, and that kind of makes sense. Maybe they got better. Then the people who did worst were the people who were randomised to the late arm but then got dialysed. So, and then the people in the middle who got dialysed early were sort of like in the middle group sort of outcomes. So I guess the question asked is if you can select out the patients that you know are definitely going to need dialysis, should maybe we dialyse them early? But how do you identify those groups? So half the people in the delayed arm never got renal replacement therapy. So again, I don't know, have a think where your bias would be with regards to starting. A few other things, so post hoc analysis was done that was interesting. So if you've got chronic kidney disease, of which 10% of the patients they had a significantly increased risk of death with early renal replacement therapy. And if you had severe acute kidney injury with sepsis or ARDS, there was potentially a mortality benefit with early renal replacement therapy in those subgroups. The next study out is 2018 is the IDEAL ICU. I'm not a fan of this study particularly. Multi-centre randomised control trial of N equals 488. They didn't meet, they had to stop after their second interim analysis, having only recruited half of the patients they wanted to. They used the rifle criteria, adults with septic shock, randomised to delayed, which is within 48 hours, or early if, sorry, delayed was the absolute indications and early was within 48 hours. Mortality at 90 days was no difference between the two arms. Now, so this is last year's trial, the STAART-AKI trial. I don't know whether you ran it here in the UK, in Leicester. So it's a multi-centre randomised control trial, a nice big trial of over 3,000 patients across 168 different centres. It looked at adults in ICU with renal dysfunction. They used creatinine, sort of just de novo creatinine, so of more than 100 in women and more than 130 in men. That's got its own problems, I guess. And severe acute kidney injury by the KDIGO stages 2 to 3. They excluded anyone who'd had indications for it, obviously emergency renal replacement therapy, those who'd had it previously, anyone who had chronic kidney disease, or any weird and wonderful causes of acute kidney injury. So they randomised either to a standard, which is as you can see, I won't read it out, but it's on the screen, what we'd call pretty standard indications for renal replacement therapy, and I think we'd all probably be happy to dialyse at those points, versus accelerated, which is within 12 hours of meeting KDIGO stage 2. Their primary outcome from any cause was death at 90 days, and there was no difference between the two groups at all. So the relative risk ratio was 1 exactly. There was no difference in any of the secondary outcomes. So with regards to their composite of death or dependence on renal replacement therapy, there was death by day 90 in ICU, or 28, or hospital length of stay. There were more adverse events in the early group, which is the things we talked about, like hypotension and hypophosphatemia. So I was in a centre that was trying to recruit to this trial. It was an absolute nightmare to recruit to because there was no equipoise. Clinicians had very clear bias to, I think my patient would benefit from renal replacement therapy now, or I don't want to dialyse them now. I don't think it'd be good for them. I would want to wait till later. So it was an absolute nightmare. And if you look at the numbers of patients who were eligible for the trial, but was never randomised, it's enormous. So an enormous, very few people that could have been entered into the trial were entered because of so much clinician bias. And I think one of the problems I have with a lot of the renal trials is that there's so many other non-renal factors to consider whether or not you dialyse someone. So I was in a liver transplant centre at the time. If you've got fulminant liver failure, I'm going to dialyse you early. I'm not going to wait for whatever renal criteria. Or it was also an ECMO centre. You know, fluid balance is crucial. You know, there is lack of equipoise. Final thing I just wanted to say was a concept. So Ronaldo Bellomo, who's done a lot of the renal research, talks about this idea of diallotrauma, which is why he says that early dialysis might be harmful. So I think we look at the big picture of, you know, my patient's fluid overloaded, we take some fluid off and we'll do some ultrafiltration. And what I guess the idea is that we ultrafiltrate and then the extravascular water will move intravascularly. But he believes that there is potentially harm from the microcirculation of those fluid shifts, and we're pulling fluid out of the intravascular compartment, and those poor little capillaries and the microcirculation are getting collapsed and damaged whilst we're waiting for the central compartment to fill back up, and there's potentially a harm related to our ultrafiltration rate specifically, rather than the whole sort of just concept of initiating renal replacement therapy early versus late. So the summary of these trials is they pretty much all showed that early renal replacement therapy, maybe unless you're a cardiac surgery patient, isn't beneficial. So that's now standard. And the idea behind AKIKI 2 is that, well, so now delayed is standard, is more delayed better.
So hi, I'm Kat. I'm one of the ACCPs at Glenfield, and I'm just going to have a bit of a chat through AKIKI 2, just with a bit of background of what AKI actually is and how we treat it. So acute kidney injury, which can be defined by a number of systems which all essentially encompass the same parameters, so an acute rise in creatinine, and a fall of urine output. All this is important to know because 1/3 of the patients, our patients that are admitted to ITU will develop an AKI with around 5% needing renal replacement therapy, and it's associated with an increased morbidity, mortality and length of stay. This is going to be complicated. So again, I know Eden's talked through some of these sections, so I just looked at what the staging of AKI was, and they can be broken down into stages of severity. And in essence, most of these studies have looked at AKI stage 3, which is anuria, when talking about starting renal replacement therapy. And then we look at management of how we treat AKI within the ITU at the moment, and there's it's about treating potential causes of AKI, ensuring sufficient blood volume, perfusion of the kidneys and supportive treatment. Mainstay of treatment obviously is renal replacement therapy. And then obviously renal replacement therapy does what it says on the tin, replaces the role of the kidney. There are a number of options, all of which were involved in the AKIKI trial, which is intermittent hemodialysis or peritoneal dialysis, which we rarely see on our ITUs here, continuous hemofiltration or combined with a dialysis for hemodiafiltration, or combinations of the two. Essentially, they differ in terms of the physics of how they work. So what are the indications for using renal replacement therapy at the moment? So a lack of renal function causing physiological issues, so acidosis, refractory hyperkalemia, pulmonary edema or symptomatic uremia. We can also use it to remove dialyzable drugs or toxins. And there is some evidence and argument for using it for sepsis because it will reduce circulating cytokinins and toxins. So there are multiple things to think about when considering starting renal replacement therapy. It's not a simple case of putting a vas cath in and plugging them into the machine of your choice. So looking at mode, there's no evidence to favour one over the other. Most RTUs here use continuous, causes less fluid shifts. There is some evidence that continuous reduces the long-term requirement for dialysis and dependent versus intermittent form. So filter for the proteins and most drugs, and then dialysis for the smaller molecules and electrolytes. Combination of the two is CVVHDF, which improves efficiency. So looking at intensity, how much to filter more aggressively can cause more fluid shifts and hemodynamic compromise. Timing is the big question that the paper looks for. Do we start when AKI3 is diagnosed, or give it some time, or if it's an emergency, i.e. life-threatening hyperkalemia, pulmonary edema? There's a large debate that's going to be ongoing about the right timings for starting renal replacement therapy. So, as Eden has kindly pointed out, there have been several studies in recent history regarding evidence of when to start renal replacement therapy, and there's no real evidence either way, early, e.g. at the time of diagnosis, or leaving it a bit longer, 1 to 2 days. STAART-AKI, as you said last year, suggested we wait. AKIKI 1 in 2016 showed no difference between starting at time of diagnosis and starting it when there's a harder indication. So AKIKI 2 wanted to look at the impact of delaying starting even more. So AKIKI 2 was a French study carried out in 39 ICUs. It was an unblinded, prospective, open label, as it's hard to blind or disguise your renal replacement therapy machine, and it was a randomised controlled trial. Recruited all patients with stage 3 AKI and another organ support, i.e. either ventilation or inotropic support. Randomised between usual case, which is 12 hours after diagnosis, and delayed or emergency indication. So it was a pragmatic methodology, meaning the exact type of renal replacement therapy was left to the centre, enabling the centres to use the mode they were most familiar with. It was randomised, balanced for each centre to avoid any impact on the results, so they had an equal amount of delayed and extremely delayed patients. The outcomes they looked at were the primary outcome looked at days free and alive of RRT up to 28 days. There are a number of secondary outcomes which looked at long time scales, i.e. mortality, number of times on renal replacement therapy, timing to start renal replacement therapy, and so on. Starting to look at the results, they recruited over 5,000 patients and screened them. However, 278 were recruited, of which the baseline characteristics of all the patients were similar, so they all had similar reasons for admission, all had similar inotropic support, ventilatory support, etc. And they did the original study was to look at late versus extremely late, which is they used a univariate analysis on comparing one variable at a time, e.g. delayed versus more delayed vasopressors versus no vasopressors, and ventilation, no ventilation. What they found was no difference in renal replacement therapy free days. Few patients in the more delayed arm actually needed renal replacement therapy, which is what they found in AKIKI 1, and no mortality difference between the two arms of the group. However, they then added on a secondary multivariate analysis post their initial study, which looks as though it was a bit of an ad hoc add-on, and the use of more complex statistics techniques, adjusting for factors, comparing delayed versus more delayed, adjusting for whether on a vasopressor, etc. Found that once adjusted for the number of other features of the patients, that there was an association between the more delayed strategy and an increased risk of 60-day mortality. However, the study wasn't powered for this in a secondary outcome, and the p-value is not adjusted for the multiple comparisons. So is this just an accidental significant finding? I.e., if you did 50 statistical tests, would one of them by chance come back with the p-value that they found in this case? So looking at the strengths and weaknesses of the paper, positives, the study was fairly large for an ICU standard study. It was pragmatic in design, adds a realism factor, making results more generalised because all the centres used the modes of treatment that they were more familiar with. Typically, ICU studies are negative in that it shows no real difference, and that's what they found here. Negative points to the study was it was confusing as its positive results from the multivariate analysis as discussed previously focuses only on the stable AKI stage 3 patients, and quite a lot of the screened patients excluded due to needing renal replacement therapy prior to randomisation, which was surely the whole point of the study. French centres use a lot more HD and intermittent techniques than we do, so whether it's comparable, I'm not sure. So, conclusions for practice. I guess the main take home is that we still don't know what is the best time to commence renal replacement therapy, and what we are doing is probably the right thing. And further research now probably needs to look at individualised patient decision making and risk predictions, rather than using a risk prediction for a group of people. That's it. Has anybody got any questions? Is there anybody still there?
Yeah.
I think what's quite really striking is that they screened 4,000 patients,
but only recruited 100.
278 out of over 5,000 patients that recruited to the trial, and they discluded them because they needed therapy at the time of randomisation, which you would have just thought they would have to the delayed stages rather than the extremely delayed stage. So they'd have missed all those patients. Anybody else got any questions?
Take home messages, keep doing what you're doing.
Yeah, absolutely.
Keep
I think it's
carry on.
individualised patient care, isn't it, rather than trying to group everybody together.
Dr. Bell, shall we leave it to you?
Well, maybe not, but I mean, I think exactly what Kat's saying. Really, I think both those trials. I think all the trials have been quite good and quite helpful in kind of telling us what we're doing. I think exactly as Kat says, it just sort of comes down to kind of individualisation for the patients as to when you start this. You start kind of the renal replacement really. Again, I think as Idun said, I think if you've got someone who's metabolically, all over the place, really catabolic with something like liver failure or severe sepsis, you probably don't want to delay kind of putting them on the filter. Whereas on the other hand, if you've got someone that's had kind of an acute insult, where that's just hypotension, a period of hypotension and surgery that's been kind of resolved, and then they're sort of on ITU but oliguric, if you reverse that insult, you're probably safe kind of waiting a bit longer and see if the kidneys recover. And I think certainly STAART-AKI or STAART-AKI, sorry, it's sort of quite reassuring that it probably is okay to wait a little bit at least. We don't have to rush in. We put these people onto filters. Is my thoughts anyway.
So given that we know that there isn't a great deal of difference between the timing of starting renal replacement therapy between waiting a bit longer and waiting a lot longer, but we do know that there is a worse outcome in, for instance, in cardiac patients who end up filtered, they have a poorer outcome. In COVID patients who get filtered, they've got a significantly poorer outcome compared to their counterparts. Should we wait even longer than we already do?
Is that a question for me?
Yeah.
Oh, cheers, Matt. So again, I don't know. I think it's very, there's a lot of confounding with all these. There's a lot of theoretical benefits of waiting, but as Kat said, as everybody else has said, there's also theoretical kind of harms of waiting. As you say, with sort of the COVID patients, the fact that the ones that ended up filtered did worse, well, probably just a sign of they were generally kind of worse overall, really.
Yeah, they're just sicker.
Yeah, exactly. I mean, again, sort of touching a bit on what Idun has said, there is harm from putting someone on the filter. Among the things she said, as well as there's also kind of increasing evidence that putting blood through a filter is kind of an inflammatory process, and that's often why you see when patients start on the filter, the urine output can just kind of completely deteriorate and disappear off. So, I mean, I don't know. I think I'm certainly, if you put me in kind of put people in sort of a spread of where they are, I think I'm probably in a later group to start dialysis or start filtration. But equally, there are some patients that land on the unit, like I say, probably the cardiac patients that are metabolically absolutely deranged, and you probably just need to sort of not muck about and actually get them on the filter, really.
I think even with the cardiac patients as well, we tend, unless they're really metabolically deranged, acidotic with low pH and hyperkalemic, you really wouldn't start them on a filter these days. We would wait to see. Again, bearing in mind that following cardiac surgery, they would have had a significant stress response with ADH and everything else. So they are oliguric, but sort of resist the temptation to put them on a filter, despite that oliguria. I guess with cardiac surgical patients, because they've got myocardial stunning, you do not want. But you think my personal preference is not to for them unless they're metabolically hugely deranged. And those patients who've been metabolically deranged when they come from theatres, they come with unapproved, they probably have a balloon in situ as well, they've had long bypass time. We recognise but the general thing would be to delay filtration even regarding patients.
You don't need to insult each other on the chat.
Sorry?
Sorry?
Harris has said that surely frusemide fixes everything, which I think Dr. Bell has taken the wrong way.
I thought it's more often Richard that's doing that to wind me up, but I mean, to be fair, I think frusemide does have its role actually. I know kind of it's always been taught not to give frusemide for AKI, but I think there is a role in it, certainly if you're overloaded. But yeah.
And that would be the thing in cardiac surgical patients. I think frusemide would, in the immediate post-op period, because they do have myocardial stunning. I think that is probably where you would want to use some frusemide, not because you're worried about the kidney function, but mainly because you want to offload it a little bit.
I think Sam's got a question.
Sam.
Thanks, Matt. No, I agree. I agree with Ricky. I think, particularly in cardiac patients, it's very difficult to find an evidence with the exact time that we should start initiating treatment. In my opinion, from my experiences, using the least invasive way to achieve your targets is the way forward. But for me, it's more the trend. If using the less invasive measures to control the fluid status and the metabolic acidosis is not working, obviously it's the point where I decide to put someone on filter. That makes sense.
Brilliant. Any other questions? Any other comments from anyone?
No.
No? So thanks everyone, that was really good. Some good speakers and well done to everyone for the talks. I think Zoe's going to put the QR code up for people to stick on there to get their feedback forms done, which is really helpful, and thank you everyone for doing that. And next week we have Dr. Mary Martin, who's one of the haematologists. He's going to talk to us about leukemia, bone marrow transplant and haematology patients on ITU, so that should be really interesting. And then we have Eden's going to talk about the TRICK trial, and Andy Prendergast is going to talk about Reality, which is the novel paper for the week. We'll stick the QR code in the chat as well, so people can scan it on their phones if they're watching it on their phones. And if everyone's happy, just give you a minute to get that, and then we'll see you all next week.